Pakistan's 2018 National Nutrition Survey found anemia in almost 55% of adolescent girls and more than 40% of women of reproductive age. Among pregnant women, 46.9% were iron deficient and more than 80% were deficient in vitamin D. These deficiencies can restrict fetal growth, affect birth weight, and leave a newborn with reduced nutritional reserves. Some children therefore begin life at a disadvantage before breastfeeding or complementary feeding even starts. This is where we begin Act for Nutrition, a special DawnMedia series examining Pakistan's malnutrition crisis ahead of a conference in Islamabad on September 2nd and 3rd. Joining us today is Professor Dr Sajid Maqbool. Together, we will trace the child's journey from the mother's health before conception to the baby's condition at birth and the care required afterwards. Assalamu alaikum, Dr. Sajid. Thank you so much for joining us on the show. And as as I mentioned in the introduction, we're going to be covering the first 1,000 days of the baby. And, a lot of people don't realize that a child can be born malnourished. We never have those conversations. The mother's health, even before the baby's born or even before the baby's conceived, really affects what the ultimate health of the baby is when they're born. So I just wanted to jump right into this and ask you, Pakistan's National Nutrition Survey says that 55% of adolescent girls are anemic and they have a lot of other deficiencies. But in your opinion, which nutritional deficiencies cause the greatest concern when a woman enters pregnancy, and which should ideally be corrected before conception?
Well, to begin with, the lot of our pregnant women in particular, but women and young girls in general is not very healthy. A lot of adolescents and young girls are malnourished.
Yes.
And therefore, they enter pregnancy, which is often unplanned,
Yes.
and they start with a big disadvantage. Now, although we think of iron deficiency as the commonest deficiency, that is probably true worldwide. Very common in teenagers and also adolescents and during early pregnancy. You'd be surprised to know that there are other nutrients that are also very deficient. I think the last survey that was held showed that maybe vitamin D is even more prevalent than anemia or iron deficiency. I think the numbers were 47 or so for iron and something like in the 80s for vitamin D.
79.
Yeah,
Yes.
something like this. So, I mean, vitamin D was even higher. And then you have two areas that you need to cover. One is what we call the macronutrients, protein deficiency, etc. And then you have the micronutrients that are in small quantity. Folate, for example,
Yes. Yes.
is very, we have deficiency of folic acid. We have a deficiency of vitamin B12. We have deficiency of zinc. We have deficiency of vitamin A, for that matter. We have deficiency of iodine. We have deficiency of calcium. So what I'm saying is that a woman who should be in good health, it follows that she will deliver a healthy baby. If she's herself deficient, for example, if her bones are weak, her physical structure is weak, she is low weight, she is low height, her bones are not as healthy, her blood is not sort of working optimally, then the baby that she's going to produce is going to have a lot of problems. And so it's very important to focus on the health of not only the mother, but even before pregnancy. So, yes, it affects the baby. It definitely affects the baby. To answer your question, yes.
And from the child's perspective, which consequences of poor maternal health may already be set in motion during the earlier stage of pregnancy?
Well, one I've mentioned already. You see
Yes.
that this is if she doesn't eat well during pregnancy, for example, she doesn't gain enough weight, then that affects not only the fetus but the placenta. It
Right.
affects organ development. It affects the brain development and whatnot. So it is very important that she be very healthy before, before the birth of the baby. It's very important in the first trimester, which oftentimes, because these pregnancies are unplanned and they don't know. So
Right.
it's not that they get extra attention. And like I mentioned, folic acid, very important in the first 4 weeks when
Right.
organs are developing, the brain is developing, when the spine is developing. So you have deficiencies of that. And brain is, just as important as the body. So you have to be cognizant of that. That does not mean that the second or the third trimester is not important. They're equally important
Right.
for gaining weight, and getting immunity from the mother, and any of deficiencies will impact on the baby. Now, how does it impact on the baby? You can have a baby who is what we call um, premature, which means that the baby is born a little early. Now, it may not be directly linked to nutrition as such, but a woman who is not
Right.
in absolutely good health may deliver prematurely. So, in that sense, yes, nutrition. Now, babies may be what we call small, they may be low birth weight.
Yes.
You can have a low birth weight baby because that's the way it is in some families. It may be genetic, yes, but there are babies who don't seem to be growing the way they should, what we call intrauterine growth restriction, or
Yes.
not growing properly. So you've heard the term low birth weight, and maybe at least anywhere from 25 to 40% of our babies are below 2.5 kg, which is the sort of the standard definition. And although prematurity has other reasons, and fortunately, the percentage of premature babies is much less, but the low birth weight babies, the percentage is high. And yes, you can also get a third category of a malnourished baby, which may neither be uh, uh, premature nor low birth weight, but malnourished.
Right.
So you can recognize those babies by physical signs, just like you do in an older child, with loss of body fat, very lean, thin muscles. Even the umbilical cord is affected, and the length may be affected, and so on and so forth. So you can see signs of malnutrition very early on, also.
So during the pregnancy stage, how do you determine that a fetus is not growing adequately, and what can still be done once growth restriction is detected? How do we sort of preempt this?
Yes, well, the obstetricians have some wonderful full ways of finding out. One, of course, is the weight that the pregnant woman gains. There is a standard that they follow. Then they follow the progress of the pregnancy by different ways. They check what is called the fundal height. Fundus is the upper part of the uterus, and so they check it physically, or they do an ultrasound. So they check it with that, and then they see the progress, your expected progress. And then there are
Right.
other technical ways of finding out whether the fetus is growing properly or not. So, but these ultrasounds, which are not invasive, not expensive, easily available, cause no discomfort to the mother. You can actually measure the head size, which tells you a lot. And they use the what we call the biparietal distance, or also they look at the weight. They can assess the weight, and they
Right.
can assess the length for that matter. So they use the ultrasound quite a bit, along with the baby's progress in height, weight, head circumference. All of these are measured. So that's how we get to know.
Um, but generally, are women receiving antenatal care early enough for these interventions to work?
Well, the point is again, in as far as I'm concerned, they aren't. They should
Right.
be receiving much more. But I do feel that it is best to have a population of young girls that are healthy. So
Yes.
our nutrition focus should start in schools and colleges
Right.
for both boys and girls, especially for girls. Now, if you go to the rural areas, they may not have the kind of facilities that they have in the larger centers or larger cities. But it's not always the problem of rural areas or underdeveloped areas. It's even in developed areas, it's the awareness of what is important in nutrition. You can be in the city of Lahore and eating the wrong kinds of food
Right.
and still have a malnourished baby. So, or a baby who's low birth weight.
And culturally, we sort of associate obesity and an overweight pregnant, eating a lot during pregnancy with, potentially having a healthy baby. We misinterpret that.
Although there is a particular weight gain that you require, and I'm sure the obstetricians will tell you that. But uh, you know, um, malnutrition works both ways. You can be underweight, undernourished, but obesity or being overweight is also a form of malnutrition. And
Exactly.
so we are seeing the this is the converse effect, is the other. And we're seeing, rising trends in adolescent obesity. And that's not good. That's not good. That's equally harmful
Right.
during pregnancy. And it adds, amongst the other problems, in addition to the other problems, it adds to conditions like high blood pressure. It adds to diabetes, for example, and it is a precursor for heart disease, etc.
Yes.
Not only in the woman, but interestingly in the aftercoming baby.
And I don't think a lot of people have that awareness that you can pass it on onto the unborn child.
It is, a lot of people don't think about it, but that's
Yes.
what's happening. Unfortunately, a lot of our youngsters are now into what we call fast foods, with refined sugars and additives and preservatives and whatnot. And they think it's a healthy mix, but it isn't. And therefore, we are seeing the other side of this nutrition aberration, as I call it, is obesity. And it has, like I said, all of its problems.
Gee. Can maternal supplementation during pregnancy improve the baby's nutritional reserves, or does it mainly reduce the risk of prematurity or low birth weight?
Yes, actually, it does. It does. Nutrition during pregnancy is very important. The question is, does it always bring down the percentage of prematurity? All the surveys and all the research hasn't sort of documented that it makes a significant difference to prematurity. Now, let me explain this to you. Prematurity means that a fetus is growing. So let's say a pregnancy lasts until 40 weeks, okay? Now, at 28 weeks, there is a particular weight, for example, 1,000 grams, and so on and so forth. Now, the baby is growing normally. It's just that it doesn't go full gestation, doesn't go to 37 or 38 weeks. It is born early. So, in that, I think nutrition may not be as important as, for example, in the growth restriction, the word that I used, intrauterine growth restriction, that a lot of people call small for gestational age, which means that if you are born at 38 weeks, instead of being 3.1 or 2 kg, you are only 2.5 kg or you're only 2.8 kg. So that's called small for dates. Dates means gestation. So small for dates. There, the if this is purely nutritional and not genetic, and not because of some congenital disease, etc., then yes, it has an impact. It has an impact, and you can. I don't recall the percentages now, but I think the figure that I remember from some of these reviews is maybe 16, 18% difference in those who are fed properly and those who aren't during pregnancy. Now you're talking about during pregnancy, not
Right.
before pregnancy. Yes. So it does make a difference.
It does. And so when we so we've made the distinction between a premature baby and a low birth weight baby, or a sort of, a baby that doesn't weigh enough when it is born. When can a newborn accurately be described as malnourished rather than simply small or premature?
That's a tough one. Yes, but technically, yes. You know, a doctor, a good pediatrician can determine. Now, I remember I mentioned a baby may have an adequate, may not have adequate weight. And when you look at the baby, it's the ratio between the fat and the mass
Yes.
that the baby has, that may be the loss of what we call subcutaneous fat. Even the buccal fat here from the face disappears. So the baby has like an old
Yes.
person appearance, a wise man appearance. So I mean, those are those are ways that you can detect, malnutrition in the newborn. So yes, to a certain extent, intrauterine growth retardation or restriction is also a form of malnutrition in a
Right.
sense. But it doesn't sort of affect pregnancy, like I said, but does not affect prematurity directly, like I said. I mean, a malnourished woman is likely to produce, it is one of the risk factors of prematurity, but there are other factors. There are other factors
Right.
that cause prematurity.
Um, and which newborns can achieve healthy catch-up growth? If they're malnourished at birth, if they're premature, which newborns can achieve healthy catch-up growth, and what must be monitored beyond weight? Because obviously, when we're doing the catch-up growth and rapid weight gain happens, that also isn't an ideal situation. That can also lead to consequences. So, what what is the criteria for that?
Well, those that are intrauterine growth restricted because of something that happens while the fetus is in utero or in the uterus, when they're outside of this influence and when they're given adequate nutrition, they catch up very quickly.
Right.
So these babies, interestingly, may not be, their height may be all right. Their head circumference may be all right, the size, head size, but the weight is the only thing that is reduced. So you can look at these babies and you say, this is the baby who will improve given adequate nutrition. And
Right.
I might put in a word for the importance of breastfeeding initially, and of course giving the right kind of nutrients. So these babies catch up very quickly. The premature babies take a little longer, and but even those will catch up. Most of them by about 1 year of age. So what you give the baby after birth is equally important, and what the baby gets before birth in terms of the maternal health is just as important. Yes.
So in an ideal scenario, a mother has, the same OBGYN that is checking her will end up being the one that delivers the child. But in a case that isn't the same, that it's a different team, what information from pregnancy should always be handed to the pediatric team at delivery, but it's commonly not communicated? And what information is essential for that team to know?
Yeah, I think the better coordinated the obstetrician pediatrician team is, the better for the baby. And at least in most larger cities, larger centers,
Yes.
there is a very close collaboration because the pediatrician always wants to know what the state of health of the mother is, and because it influences not only the nutrition, but the other issues. For example, if the mother has high blood pressure, or the mother is obese, we mentioned obesity, or if the
Or
mother
diabetes or
or
something.
diabetes or asthma or
Right.
even a heart condition, then it is likely to affect the baby. And the pediatrician needs to know. Now, even if it is not the same obstetrician, and happens often, they switch obstetricians or they go from one place to the other. These days, you have the medical records, and they usually contain information about the mother
Right.
already. So it is passed on. And this good collaboration between obstetrician and pediatrician is absolutely essential for the welfare of the baby.
So now let's talk about preventing, a high-risk birth, a premature birth, from becoming a cycle. Especially in the case of the same mother, and especially in a society like ours, a lot of children are back to back, very less. There's very little space in between. So, what should postnatal care provide to help a woman recover nutritionally before another pregnancy? Not that she has a lot of control over it sometimes.
Yeah, that's the issue. She doesn't have a lot of control over it. To begin with, she shouldn't have delivered so early. For example, a lot of what we call teenage pregnancies.
Right.
I mean, I shouldn't say adolescent pregnancies. I should
Right.
say. So she should not be ready to deliver at a very young age, because she's not only not ready physically but also emotionally, mentally, which is just as important. And then it should be planned, it should be supervised. There should be antenatal care. So somebody can tell her, listen, you're going to take folic acid, you're going to take iron, you're going to take vitamin D. You need to increase your proteins. You need to increase the calories that you get, etc., etc. And see, the if the interval is very little between one pregnancy and the other, the mother doesn't have time to recover, and
Right.
her doesn't recover. Now she's breastfeeding also, let's say,
Right.
and for that also she needs to be in optimal health. Because
Right.
if she's malnourished, she's not going to produce enough proper quantities of milk. It may not be as healthy. If she's herself vitamin D deficient, she's not going to, be able to provide the same sort of nutrition to the baby. So the interval itself, if it's very small, causes a greater chance of prematurity and again
Right.
of low birth weight. So you have to, if you can't during the first pregnancy, the obstetricians explain to them that now they need to look after their nutrition. They need to give an interval between this and the next baby. Let the body recover, gain strength, get adequate nutrition, and then go on to the next pregnancy.
In an ideal world.
And then, yes, we're working on it.
So, if policymakers could track only three indicators, which would best reveal whether maternal and newborn nutrition services were working?
Oh, that's a tough one. Okay. I would say I mentioned anemia,
Yes.
and I mentioned folic acid. I think pre-pregnancy, this is very important. If you can sort of find out how many of these are getting the iron and the folic acid before pregnancy is a parameter.
Right.
And then how many are anemic during pregnancy? Because iron
Right.
deficiency is very common. I think
Right.
that's another parameter. And the third, obviously, is the outcome, which is weight of the baby. It is difficult to tell you just two or three, but I think if you were to, from a public health point of view, you
Right.
could look at the nutrition of the mother before pregnancy, of let's say her iron and folic acid supplementation, and what percentage are being given that. So let's say if it's a high percentage, that's a good marker. That's very
Right.
good. Second is during pregnancy, how many of the mothers still remain what we call anemic, or low
Right.
hemoglobin, that could be a very easy marker. You could easily check that because you
Right.
don't need to check the folic acid towards the end of the pregnancy or the second or the third trimester. And the folic acid comes very early. And I think the third is the outcome, which is the weight of the baby. I mean, if we're talking low birth weight of, let's say, anywhere from 25 to 40%, if we can reduce that from a public health point of view, that's a very reasonable way of measuring the impact of a good nutrition program.
And vitamin D deficiency also, I feel like that is something that is so common because, I mean, I obviously not in rural women because they actually, they do Mazduri and all of this, but like in urban cities, women get out so little, the vitamin D deficiency is quite an issue.
No, I mean, I didn't imply that the others aren't. But when you're talking public health, when
Right.
we're talking large scale population,
Yes.
assessments, the easiest to assess is hemoglobin, or
Right.
like vitamin D levels are not easily available.
Right.
They're expensive to do
To
and
test,
whatnot.
yes.
Yeah, so I mean, you were talking about some sort of a parameter, and I think that's
Right.
an easier parameter. But I agree, and I already told you that there are many vitamin deficiencies that these babies face.
Right.
These mothers face, and
These
therefore.
mothers face. Thank you so much for joining us. Again, we're trying to cover all of the conversations that don't happen regarding childbirth. We basically think about the whole process of the child's life as soon as the child is born, but we don't realize that everything that happens before the child is born is just as integral to the child's health. And thank you so much for contributing to that conversation and giving us so much clarity.
Sure, thank you for having me, and I'm sorry that I won't be present at the conference in Islamabad. That's my loss.
Thank you so much for joining us. A child's nutritional history can begin with an anemic adolescent, an undernourished mother, or a pregnancy in which poor fetal growth is identified too late. Preventing stunting requires continuous care before conception, during pregnancy, and after delivery, linking the mother's health with the child's development. That connection will remain at the center of DawnMedia's Act for Nutrition series as we build towards the conference on September 2nd and 3rd. In episode 2, we follow the child home and examine why nutritious food may still fail to support growth when contaminated water, poor sanitation, and repeated infections remain part of daily life.
ACT Pakistan, advocating change together, a Dawn Media initiative.